Hi again, it's me, Professor Kemper. So today we're talking about peripheral vascular assessment. And when we assess peripheral vascular status, we're asking, is blood getting to where it needs to go? Is it returning effectively? So we're looking at both arterial circulation, which is the outflow, and then venous circulation, which is the return of blood. Beautiful learning objectives. Here we go today. Love. And we're going to briefly review the arterial system because understanding the structure of arteries helps explain what we see in peripheral vascular disease. So arteries carry oxygenated blood away from the heart under high pressure. Because of this, their walls are really thick, strong, and elastic. So we have layers to the artery, which there are three, and you'll see these labeled on the slide. So we have our inner layer, tunica intima, made of endothelial cells, which is a smooth surface for blood flow. This is where atherosclerosis begins, so that plaque buildup that damages this layer. Then we have the middle layer, tunica media, which contains smooth muscle and elastic fibers. It's responsible for that vasoconstriction and vasodilation. This layer helps control blood pressure and flow. And then finally, we have the outer layer, the tunica externa. It's made of connective tissue and it provides structure and support, and it helps protect our vessel. So this slide shows the major arteries throughout the body, and this is important because these are the sites where we assess pulses and perfusion. So big picture here, we want to remember that arteries carry oxygenated blood away from the heart. They deliver oxygen and nutrients to tissues. So if there's a problem here, it really directly affects perfusion. Major artery landmarks, so you don't need to memorize every artery, but you do need to know where the key ones to assess are. So we have carotids, which are located in our neck. We have brachial arteries, which are located in our arms. These are used for blood pressure. Radial in our wrist, femoral in our groin, popliteal behind the knee, posterior tibial in the ankle, dorsalis pedis, which is top of the foot. These are your main pulse points. And when you palpate pulses, you're assessing the blood flow, cardiac output, and peripheral perfusion. We're always comparing side to side, so right with the left or left to the right. And if blood flow is reduced in these areas, we may also see things like weak or absent pulses, cool, pale extremities, delayed capillary refill, and pain with activity, which is known as claudication. Now we're shifting to the venous system, which is just as important as arteries, but for a different reason. So if arteries are about getting blood to the tissues, veins are about bringing it back to the heart. So veins carry deoxygenated blood back to the heart under low pressure, and because of this, they rely on valves and muscle movement like walking to help push blood upward, especially from the legs. So you'll see major veins labeled here, but really we're focusing on the jugular veins, which reflect right-sided heart pressure, peripheral veins in the arms and legs to assess for swelling or circulation, and deep versus superficial veins, which is important for things like deep vein thrombosis or blood clots. So when venous return is impaired, blood flow starts to pool in the extremities, and this can lead to edema, venous stasis, and skin changes. It also can lead to increased risk for blood clots. So key signs of venous problems would be venous insufficiency, which is warm skin, edema, brown discoloration, aching or heavy feeling in the legs, and then ulcers near the ankles, and they're more superficial ulcers. Now we're talking about capillaries, which are the smallest blood vessels, but arguably the most important for tissue function. So the connection between arteries and veins. So capillaries connect arteries via the arterioles to veins via venules. So they act as the bridge between delivery and return. And their primary function is to exchange. So this is where the real work actually does happen, the exchange of oxygen, nutrients, and waste products between the blood and tissues. Oxygen and nutrients move out of the blood, waste products and CO2 move into the blood. And so flow through the capillaries, you want to think of it like this. Arterioles deliver oxygen and nutrients, and capillaries allow exchange, and venules collect waste and metabolites. So when capillary function is impaired, tissues don't get what they need, which can lead to poor perfusion, delayed healing, and tissue damage. And this is why we see things like diabetes, peripheral vascular disease, and shock, which can cause serious complications at the tissue level. So we don't actually see capillaries directly, but we assess them through capillary refill, skin color and temperature, and then wound healing, which can give us clues about the microcirculation. Now we're going to talk about the lymphatic system, which works closely with the cardiovascular system, especially when we're thinking about fluid balance and edema. So the lymphatic system helps return excess fluid back to the circulation. It also supports the immune system. We want to think of it as the body's drainage system. And so how it works is fluid leaks out of the capillaries into tissues, which is normal, and the lymphatic system collects that extra fluid and it filters it through lymph nodes and returns it to the bloodstream. So key structures, we have lymph vessels, which carry fluid, and then we have lymph nodes, which filter and fight infection. We also have a thoracic duct, which drains most of the body, and a right lymphatic duct, which drains the right upper body. Ultimately, lymph returns to the venous system. And when the lymphatic system isn't working properly, we get fluid buildup, which is also known as lymphedema. And this can happen with cancer, lymph node removal, infections, and chronic venous issues. And in our assessment, we're looking for any swelling, so edema, symmetry, one side or both, lymph node enlargement, skin changes. So lymph nodes should be small, mobile, and non-tender. Any hard, enlarged, or fixed nodes can be really concerning. This slide highlights the major lymphatic organs, which are essential for immune function and infection control. So beyond fluid balance, we said the lymphatic system plays a key role in defending the body against infection, and it does this by producing and housing white blood cells. So we have our tonsils, which are located in our throat, which are our first line of defense against any inhaled or ingested pathogens. That's why they often become enlarged when we do have an infection. Also our thymus gland, which is located in the upper chest. This is important for T cell development, which is our immune response. It's more active in childhood because you tend to have a newer immune system and it's working much harder in childhood. Lymph nodes, these are found throughout the body and they filter lymph and trap pathogens. And these are what we palpate during our assessment. The spleen, also helpful for filtering blood, not just lymph. It removes old red blood cells, helps fight infection. And enlargement of our spleen can indicate infection or disease. So when assessing the symptom, we focus on lymph node size, tenderness, mobility of the lymph nodes, signs of infection or inflammation, and the patient's general immune response. Important findings to recognize: tender, soft nodes can indicate infection. Hard, fixed nodes can indicate possible malignancy. And generalized lymphadenopathy can indicate systemic disease. So we always want to consider the location and pattern of the lymph nodes. Now let's talk about how aging affects the vascular and lymphatic systems, because this directly impacts what you'll see in assessment. So systolic hypertension. So as patients age, arteries become stiffer and less elastic, which can lead to increased systolic blood pressure, wider pulse pressure, which is very common in older adults. Arterial disease. So older adults are at high risk for atherosclerosis, which is plaque buildup in the arteries, and then peripheral artery disease. Chronic venous insufficiency, so over time, venous valves weaken, which can lead to blood pooling in the legs, edema, skin discoloration, and venous ulcers. Older adults are also at risk for DVT or VTE, which is deep vein thrombosis and venous thromboembolism due to immobility, sometimes surgery, and chronic illness. So we are always assessing for unilateral swelling. Venous and lymphatic issues. You might also see in older adults chronic lymphedema, which is persistent swelling that may not improve with elevation, and this can also overlap with venous disease. Very common in older adults is varicose veins, which happens through valve dysfunction and increased venous pressure. Usually it's not dangerous, but it can contribute to discomfort and chronic venous insufficiency. So when we're assessing older adults, we want to think, is this arterial or venous? Is swelling chronic or acute? Is there any clot risk to my patient, which can help prioritize our care? This slide highlights important health disparities in vascular and cardiovascular disease. So peripheral arterial disease, we see higher rates of this in African Americans of both sexes, Mexican American females, and so this means we should be at a higher index of suspicion when we're assessing symptoms like leg pain with walking, weak pulses, or any delayed healing. And then cardiovascular disease, we talked about in the cardiovascular assessment lecture, is more prevalent in African American, Hispanic populations, but still considered the leading cause of death in the United States. So early screening and education is going to be key. Hypertension is especially common in African American populations, and it often develops earlier, is more severe, and leads to more complications. So this directly impacts vascular health. Smoking, we know, is a major modifiable risk factor across all populations, and it contributes to really bad things like atherosclerosis, peripheral arterial disease, and vascular damage. So always include smoking history in your assessment. Genetics and risk factors can increase risk for atherosclerosis, hypertension, diabetes, and hyperlipidemia, which can all contribute to vascular disease. And then peripheral arterial disease is increasing worldwide due to low income, which reflects lifestyle and chronic disease trends globally. And then sex differences. Chronic venous insufficiency is more common in females in industrialized countries. Peripheral arterial disease may actually be more common in females than previously thought in the US. So it's important because symptoms may present differently or be underdiagnosed. So again, we're assessing each patient individually while being aware of risk trends. So is this patient at higher risk? Am I screening appropriately? Are there barriers to care? This slide is all about clinical priority and urgency, which is one of the most important skills that we'll have. So a big priority rule, we're always remembering acute beats chronic. So we're always prioritizing sudden changes and any life-threatening conditions over long-standing stable issues. So one of an acute emergency would be complete arterial occlusion. So this is a limb-threatening emergency. We want to think that the patient is not having any blood flow to the extremity. So key symptoms here would be the 5 P's: pain, pallor, pulselessness, paresthesia, and I can never say this one. Wow, I can't do it today. Okay. Coolness. I'll say this in class, hopefully. So the classic P's, and this would require immediate intervention to save the limb. Also, a big one would be DVT, so deep vein thrombosis. This is serious because of the risk for pulmonary embolism, which can be life-threatening. So symptoms include pain, swelling, one-sided swelling, and warmth. A key point here is we're not massaging that, and we're probably going to start them on anticoagulation therapy pretty quickly. And then we get to pulmonary embolism, which is life-threatening. where a clot has traveled to the lungs. Key signs of this would be sudden shortness of breath, chest pain, tachycardia, diaphoresis, and anxiety. Patient looks like they can't breathe and something is very wrong. They can't sit down. Sometimes I've had patients just suddenly lose consciousness. So it can be really life-threatening. So when you see any of these conditions, we want to ask what will kill my patient first, what needs intervention right now, so how you would prioritize care. This slide focuses on the 7 Ps, and we just talked about 5 of them, which are critical for identifying a vascular emergency, specifically acute arterial occlusion. So we're adding 2 Ps here. So anytime you see the 7 Ps, we want to think that we have limb-threatening emergency, and this requires immediate action. So the first one would be pain, usually sudden, severe, often the first symptom, so out of proportion to what we're seeing. Pallor indicates lack of blood flow. The word I cannot say, so the limb feels cool or cold. Cannot regulate temperature. Paresthesia, so numbness or tingling. Pulselessness, so we have an absent or diminished pulse, which is a late and serious sign. Paralysis, which is loss of movement, another late sign, and there's poor prognosis if we don't treat that quickly. And then perfusion, which is delayed cap refill, and it indicates poor circulation at the tissue level. So the earlier signs would be pain, paresthesia, and pallor, and later signs would be pulselessness, paralysis, which can help us determine the urgency of progression. This slide focuses on what we do after recognizing a vascular emergency, so how we prepare the patient quickly and safely. So once you identify that something like an arterial occlusion or DVT with complications or a pulmonary embolism is occurring, the priority becomes rapid preparation for definitive treatment. So we're preparing the patient for things like interventional radiology, like a thrombectomy or angioplasty, surgery, or both. And time is critical here. So any delays can lead to limb loss, organ damage, and death. So prepping the skin by shaving and cleansing the area in a pretty quick fashion, focusing on keeping that area clean, establishing IV access, essential for fluids or medications like anticoagulants or thrombolytics, like clot busters. Consent forms, ensuring that informed consent is signed before any procedures. And that will be done by the provider, but you want to make sure that it is signed and that the patient understands what they're signing. Patient education, even in urgent situations, we can be able to briefly explain what's happening, reduce their anxiety, and promote cooperation. We want to keep it simple and focused, that say, hey, we're concerned about blood flow, we need to act quickly and treat this. So as nurses, we're thinking about what needs to be done now to move the patient towards treatment. And you're the bridge between assessment and intervention. So this slide focuses on what the patient tells us, and this is where we start identifying risk for peripheral vascular disease. So again, before we even touch the patient, we want to understand who's at risk for arterial or venous disease and what symptoms might already be developing. So starting with past medical history, we want to ask about conditions that affect circulation, such as hypertension, diabetes, hyperlipidemia, cardiovascular disease. Lifestyle and personal habits, like smoking, their activity level. So if they have a sedentary lifestyle, it's going to increase their risk. Diet that's high in fat and high in cholesterol. Occupation, so prolonged sitting or standing. We want to think about DVT risk. Medications, we want to ask what they're taking and why. So antihypertensives, anticoagulants, antiplatelets like aspirin, clopidogrel. Cholesterol meds like statins. We also want to ask about adherence because this is going to often reveal more than the med list itself. Family history, we're looking for early or significant vascular disease like peripheral peripheral artery disease, heart disease or stroke, diabetes or hypertension. So as you gather this data, you're already thinking, is the patient more likely arterial or venous? Are they high risk for complications like DVT or ischemia? So those risk factors are really the clues before the symptoms show up. Now we're shifting from gathering data to what we do with it, so patient education, especially those at risk or diagnosed with peripheral artery disease. This is where us as nurses can make a huge impact because peripheral arterial disease is largely preventable and manageable with lifestyle changes. So risk factor modification like smoking, talking to them about their diet and activity level, chronic disease management, so needing to control underlying conditions like hypertension or diabetes because poor control can lead to faster progression of vascular disease, especially diabetes. If they do have diabetes, daily foot assessment is going to be critical because patients may not feel the injury from neuropathy. They have poor circulation, which can delay healing. So we want to teach our patients to check their feet daily, look for cuts, color changes, ulcers, and wear proper footwear, especially if they have diabetes. And then we're going to reinforce additional contributors like chronic kidney disease or family history. These are often overlooked, but do increase overall vascular risk. So now we're going to be talking about some more subjective data, teaching and health promotion for patients with venous disease. So remember, venous disease is all about blood not returning effectively to the heart, and it leads to pooling, swelling, and increased venous pressure. So our goal is simple: to decrease venous pressure and improve circulation by talking to the patients about avoiding prolonged standing or sitting, encouraging frequent movement, elevating their legs periodically. Compression stockings, these are great to help push blood back toward the heart and reduce edema and discomfort. We want to have them put them on in the morning before swelling starts and wear them consistently. Remember, we want the sizing to be correct for their legs as well, because if they're too big or too small, they're not going to work properly. DVT and PE education, patients must know when to seek help. So signs of DVT, which would be unilateral leg swelling, pain or tenderness, that is sudden, warmth, redness, and then for pulmonary embolism, any sudden shortness of breath, chest pain, tachycardia, anxiety. Because remember, that's an emergency. So key symptoms that the patients report with peripheral vascular issues, where we're starting to distinguish arterial versus venous problems. So when patients describe symptoms, you should be thinking, is this arterial or venous? Like we've talked about. So pain is one of the most important clues. Arterial pain would be cramping with activity, which is also known as intermittent claudication. It's relieved by rest. Venous would be more aching, heaviness, worse with prolonged standing. We want to ask about numbness and tingling, which can suggest decreased perfusion, and so we would be thinking about arterial, possible nerve involvement. Cramping, again, think arterial insufficiency, where it would occur with walking or exercise and improves with rest. This is a classic peripheral arterial disease symptom. Skin changes, arterial, we would see pale, cool, shiny hair loss. Venous, we would see brown discoloration, thickened skin, and edema. And then decreased functional ability. Patients may say, I can't walk as far as I used to, or my legs get tired quickly. Remember, in older adults, there are higher risk for both arterial and venous disease, and they may have atypical or vague symptoms, so we're not relying just on textbook presentation. So now we're talking about risk reduction and health promotions for patients with lymphatic disorders. So lymphedema, which is fluid buildup due to lymphatic obstruction or damage, often seen in patients who are undergoing cancer treatment, sometimes surgery or radiation that destroys our lymph nodes. So these patients often present with persistent swelling, often unilateral, feeling of heaviness or tightness, skin thickening over time. So this would be different from venous edema. This is protein-rich fluid, and it's harder to move. We want to teach patients to avoid staying in one position too long, and we want to encourage frequent movement and position changes to help promote lymph flow and prevent worsening swelling. Early intervention is going to be key to address lymphedema early and prevent complications, because without any treatment or early intervention, it can lead to fibrosis or hardening of the tissue, also skin breakdown and increased infection risk, which can lead to cellulitis. So now we move from what the patient tells us to what we actually assess and measure, and this is where we confirm or rule out vascular problems. Starting with inspection of the arms and legs, we're starting by looking at the color, skin integrity, hair distribution, and symmetry between the limbs. Then palpation, we're moving on to pulses, palpating the peripheral pulses, radial, brachial in the upper, femoral, popliteal, posterior tibial, and dorsalis is the lower, and we're assessing the strength and symmetry. Then we're auscultating the blood pressure, potentially Doppler, using ultrasonic Doppler to detect blood flow if we need to, if they're harder to feel. Edema assessment, we're checking for swelling. We want to press over bony areas, looking at pitting edema on a scale of 1+ to 4+, 4+ being the worst. Ankle brachial index, this is a key diagnostic tool where we are comparing ankle blood pressure to arm blood pressure, which is very NCLEX practice. It's very NCLEX tested. So the normal ABI would be 1.0 to 1.3, and then if it's less than that, we are thinking about peripheral arterial disease. Next, color changes. We're looking at arterial for any pale, cool, or dependent rubor, and then venous, which reddish brownish color. And we're combining all these symptoms to differentiate if this is peripheral arterial versus peripheral vascular, or venous, I'm sorry, peripheral venous. So again, before performing any assessment, we want to make sure that we have the right equipment to ensure accuracy and help us perform a thorough, efficient exam. So making sure that the patient is in a gown so that we can fully visualize both upper and lower extremities. We're comparing symmetry, color, and skin integrity. A non-stretchable measuring tape. This is used to measure limb circumference, monitor for edema changes over time. It can be important for tracking conditions like DVT, lymphedema, and chronic venous insufficiency. We might need an ultrasonic Doppler when pulses are difficult to palpate or they're not palpable at all, which can help us detect blood flow in peripheral, like severe peripheral arterial disease or severe edema. And with the Doppler, we'll need ultrasonic gel, sphygmomanometer, so our blood pressure cuff, using this to help us with ankle brachial index, tourniquet used primarily for venous assessment to help visualize the veins, also used during venous competency testing like Trendelenburg. And again, just making sure the patient is in a comfortable, warm position. And, oh, I just said that. Comfortable room temperature. So before we even begin the hands-on assessment, preparation is critical. So the steps that we take to set the tone for the patient comfort, safety, and accuracy of our findings. So making sure that the room is a comfortable temperature, because if it's too cold, it can cause vasoconstriction and the pulses can be harder to palpate. Proper hand hygiene, as always. Explaining the assessment to the patient, what we're going to do, why we're doing it. Gowning and draping. Remember to provide privacy. Ensuring safety with repositioning, because the patient may need to at times lie flat or sit up or change positions for certain tests. Always assisting when needed, watching for dizziness or instability. And then, of course, cleaning equipment before and after. Now we move into the actual hands-on portion of the peripheral vascular assessment, and we're going to assess both the upper and lower extremities using three main techniques: inspection, palpation, and auscultation. So starting with the arms, by visually assessing both arms, comparing bilaterally for symmetry, we're looking at the skin color, checking for hair distribution, we're observing for lesions, ulcers, or scars, we're assessing for edema or swelling. Next, we palpate temperature, using the back of our hand, capillary refill, which should be less than 3 seconds, pulses, radial, brachial, assessing the rate, rhythm, and amplitude, always comparing side to side. Then auscultations for the arms. Auscultation is less common, but it could be used to indicate, we can listen over the arteries, like the brachial, for any bruits, for turbulent blood flow. For the legs, we're starting with inspection. We're moving to the lower extremities, assessing color, pallor, rubor, cyanosis, any hair loss or thickened nails, any ulcers. We're checking for any varicose veins or edema. Then we're palpating temperature, palpating edema to look at grade and location. Palpating pulses, the femoral, popliteal, and posterior tibial, and dorsalis pedis. If we can't feel a pulse, we're going to use the Doppler. And then auscultating major arteries if needed, like femoral, for any bruits. Again, indicates turbulent blood flow. So beyond basic inspection, palpation, and auscultations, there's a few additional techniques that help us further differentiate between arterial and venous disease. So one is color change. If we elevate the leg to about 30 to 45 degrees and we see pallor, it does suggest arterial insufficiency. And if we then place it in a dependent position, we see dependent rubor or a reddish color, also suggestive of arterial disease. Manual compression test. This test is used to evaluate venous function, especially in patients with varicose veins. So we will manually compress a vein and release, and we can observe how quickly the vein refills. So rapid refilling may indicate venous valve incompetence, and this tells us the veins are not effectively preventing backflow. Trendelenburg test. This is a more structured test for venous insufficiency, where the patient lies down and elevates the legs to empty the veins, and we apply a tourniquet to the upper thigh, have the patient stand, and then observe venous filling. So rapid filling before removing the tourniquet can indicate incompetent veins below, and rapid refilling after removal can indicate valve issues above. So this can help us locate where the venous problem is occurring. Again, more like advanced assessment. So this is where everything comes together. So after we've collected subjective and objective data, then we will use our clinical judgment to make decisions about care, starting with analyzing any lab and diagnostic testing to help us differentiate arterial versus venous disease, reviewing labs like cholesterol, triglycerides for their atherosclerosis risk, maybe looking at their glucose or hemoglobin A1C for diabetes. D-dimer, this lab indicates clot formation. It's nonspecific, but we can use it to help us identify DVT or PE. We talked about Doppler ultrasound to assess blood flow. And then Prioritizing our hypothesis of what's going on, and we're taking action. So asking ourselves, what is the most urgent problem? Is this acute or chronic? Am I having sudden pain and pulseless limb? We're thinking arterial occlusion. Are they having swelling and warmth on one side? We're thinking possible DVT. And we're always analyzing changing findings because peripheral vascular conditions can change quickly. So we're always monitoring trends in pulses, skin color, edema, and pain, and we're documenting clearly and frequently. Interprofessional collaboration. Again, you're not managing this patient alone. Physical therapy may be involved for mobility and circulation improvement. We might have vascular specialists consulting for interventions, maybe wound care for ulcers. So collaborating with the team helps improve outcomes and prevents complications. And based on your findings, your plan of care may include improving circulation, preventing clot formation, managing chronic conditions like diabetes or hypertension, and as always, patient education of their lifestyle changes. And we're always asking, is the patient improving with the interventions? Are pulses stronger? Is edema decreasing? Is pain controlled? If not, we're reassessing, we're adjusting the plan as needed. And that is it for peripheral vascular assessment. And we are going to practice in lab. So I can't wait to see you then. Have a wonderful day.